All right, so tonight what we're going to talk about, well, first of all, I want to say thanks so much for joining in. I know at the end of the day, it's kind of tough. I struggle at the end of the day after seeing patients all day, but I do like to get this information out there because it's really important, us clinicians, but people that are trying to maintain muscle mass, build bone density, preserve or build strength, alternatives to just heavy lifting, because a lot of people can't do it due to injuries or rehabbing from something. Yesterday, I had a patient come in, had ACL surgery 2 years ago, was still having a lot of chronic pain in his knee. And what he'd been trying to do as a former Division I basketball player, he was trying to treat his knee like he did when he was in his 20s. And so my opinion was that he was overloading it, too much volume. As everybody here knows, volume, when we're talking about exercise, is the amount of weights with the amount of reps and the amount of sets. So looking at that as this big picture, clearly he wasn't having pain during the activity, but he was having pain afterwards. So he was aggravating it with either too much load or too many reps or too many sets. So that volume. So, BFR is a perfect adjunct for him to continue to try to build strength through the limb because he has full range of motion, but he's trying to just build up his quad and his hamstring and his calf and get that leg so that it's back to the same size and strength as it was prior to his injury. So BFR is great for situations like that. BFR, blood flow restriction training, is great for situations when people can't lift heavy load, or they don't want to lift heavy load because they can't have days off, like a hockey player that has a game tomorrow but needs to lift during the season. BFR is great because it doesn't break down tissue. There's been numerous studies where will have individuals lift twice a day. And so you're not breaking down tissue. You can train multiple times, or you can train between games and not experience that force reduction that you normally would from the muscle as the muscle is repairing from the injured tissue. So that's really what I'm going to talk about tonight, is those that are in chronic pain or have the need for joint preservation, why BFR is such a great adjunct. If you don't know who I am, my name's Ed LaCara. I'm a little bit of a weirdo. I started as a combat medic in the Army a long time ago, and then was a Division I wrestler, studied exercise physiology as an undergrad. During my senior, it was really my junior year of college, I tore my ACL, my PCL, my LCL in my right knee, which essentially led me to rehabilitation outside of the normal medical kind of what they wanted to do. My orthopedic wanted to do surgery right away, knowing that if I had surgery, it was so late in my junior season, I would have foregone my senior season. And so I was given the alternative to just try to strengthen it as much as I could. And that really just kind of opened my eyes that there was alternatives. I was wrestling with a brace in about 4 months after starting that journey, which was really quick. Not as quick as Lindsey Vonn, though. Lindsey Vonn tears her ACL and then is skiing in the Olympics a week later. I don't know how she did that. Anyway, she's a freak athlete. Anyway, so that was kind of my journey towards moving towards more rehabilitation, was my own experience. I wanted to help others in that same scenario. So then I went on to be a strength and conditioning specialist with the NSCA and then an athletic trainer. I didn't want to go to medical school and work in a hospital. I didn't really realize that you could work just in a private practice because my mom was a nurse and she had been in a hospital. That's all I ever knew. So I looked for alternatives, did some internships, physical therapy, some other things, and decided to go to chiropractic school so that I could see patients directly off the street, could accept insurance, run my own business, the things that I wanted to do. Decided that I wanted to do more, and so pursued a PhD in sports medicine and published some studies on lower back and some other things for rehabilitation. And then most recently, I've been on this journey to do a little bit more primary care with the emphasis of exercise and diet and micronutrients and recovery and sleep and all those things. So I'm finishing a family nurse practitioner degree in order for me to be able to do that. I use like a lot of that strength and conditioning experience, that sideline rehabilitation, locker room rehabilitation in my daily practice. And part of that is I'm always emphasizing that we need to get bigger and stronger and build bone density and all those things. It's barely ever a problem for most people to do that. So I've got fancy tools in my clinic. I've got a DEXA machine, and I've got something called an ARX that allows us to lift very heavy weight computerized. I've got a Vasper that uses cardiovascular conditioning using blood flow restriction and cooling. But I also use BFR in my rehab if people can't lift the heavy loads. So a lot of people think that I just use BFR, but I don't. I use heavy lifting whenever I can. But during rehab process, or somebody that might be elderly, my dad is 91, he uses BFR with his resistance training at his facility. My mom does the same thing. And so I use a combination of both in order to try to mix the best I can for the patient, what they need. I'm double board certified in rehab and sports medicine. And I practice out of my clinic in Dallas, Texas, called Body Lounge Park Cities. I've been with Smart Tools for probably, I'm getting pretty close to 10 years now. We kind of introduced BFR about 9 years ago when I was introduced to it as a way to increase strength and muscle size or hypertrophy without lifting heavy loads, which I thought was impossible. I was taught as an undergrad exercise physiologist that you had to lift heavy loads and break down tissue in order to get response, but we now know that is not the case. We have seen studies that I was involved with at TRX that making resistance just about to failure within 1 or 2 reps can also build strength and hypertrophy. And then we also know from BFR that we can also build strength and hypertrophy using very light loads between 20 and 30 pounds. 20 to 30% of your 1 rep max compared to high intensity training, which is normally at 65 to 90% of your 1 rep max. So we can do lots of cool things with BFR. We can do aerobic capacity training, just like steady state. We can do sprint intervals. We can do passive BFR that I'll use with patients that can't lift at all yet. Maybe they're in a cast or a brace to try to preserve muscle mass. We can use it in just a myriad of different ways. We do it in combination with high intensity training. That's what I try to personally do for my lift heavy one day, and then an alternate day I will do BFR, so I'm not breaking down tissue more. Unfortunately, at 52, it's not as easy as it used to be to do things like CrossFit and wrestle and all the stuff that I like to do. So in order to stay active and be able to ski like I did this weekend at Breckenridge without an ACL, I've got to keep my legs strong. And so BFR allows me to do that. So my virtual assistant thinks that that looks like me, which I'm not sure it does. But that's supposed to be me. So what we're trying to talk about tonight is really chronic pain. And really chronic pain is that pain that exists beyond normal tissue healing time. Doesn't necessarily mean that there's damage there anymore. Sometimes it's just this signaling to the brain that this pain mechanism has been going on, and your body can't break that. And so we try to do a lot of things in the clinic to break that cycle. We might use things like dry needling or active release technique or manipulation or scraping, cupping. All these things really don't affect the tissue very much. It mostly affects the neurological system to try to break that cycle of my brain just knowing that tissue is in pain. But when we're using these modalities, it's very important, in my opinion, that after you use those modalities, you definitely get a decrease in pain. And now we need to exercise in that, what we call a window, this window of opportunity in order to improve range of motion, increase strength in that hypoalgesic state or decreased pain state. Now, the cool thing with exercise and including BFR is that BFR also contributes to a hypoalgesic state, meaning that it decreases your pain. So what that tells me is if exercise does this, if BFR exercise does this, we have to be moving as much as we can within a tolerance. So you might not be able to do heavy, intense training, but you can do something. You can do range of motion. We can get on a bike or an elliptical. We can do something typically, not always, but most of the time we can do something, and that's going to help that chronic pain. So just defining it, chronic pain is defined as pain persisting beyond 3 to 6 months, extending beyond normal tissue healing time. It affects nearly 1 in 4 adults, and it represents a major source of disability and reduced quality of life. It often arises from injury, disease, or unclear origins, and it's frequently associated with psychiatric comorbidities. And it's rarely a single entity. There's a lot of times that we have things like fibromyalgia, which are more like a autoimmune disease. I see a lot of things that patients don't even realize, because I do a lot of functional medicine now. We find these joint pain that was told it was arthritis, but it's really a sensitivity response to things like pharmaceuticals or sensitivities to different foods or allergens. And so getting to the bottom of those really makes a big difference, or getting to the bottom of what the problem is makes a big difference, so we can overcome these conditions and get out of this chronic pain. Because what we know about chronic pain is it's psychologically. I know when I've been injured and I can't do the things that I want to do, I get depressed. when I mentioned I tore my ACL in college the first time. I've done it 3 times now, so it's kind of old hat. But after that first time, and I went from being the captain of my wrestling team to all of a sudden 7 hours a day normally occupied from weightlifting and running and wrestling and being with my teammates, all of a sudden was 0. And it was very hard mentally. And so I always have a lot of empathy for my patients that are coming in with chronic pain, because I know it's not just affecting them and weighing on their brain, but it's also affecting their loved ones as well, their family, their friends, their kids. So it's really important to me that we help others overcome this. So there's a lot of categories of chronic pain. We have neuropathic, nociceptive, musculoskeletal, inflammatory, psychogenic, mechanical, probably more than I even listed there. So just little definitions. So neuropathic pain results from peripheral central nervous system injuries. So like something like a diabetic neuropathy causing pain in the feet, complex regional pain syndrome, post-stroke, things like that. Then we have nociceptive pain, which arises from actual tissue injury or damage. So something like a sprain or strain or a burn or a post-op pain. Then we have musculoskeletal pain coming from muscles, bones, and joints, like chronic back pain or radicular pain. And we have inflammatory pain, like I mentioned before, like sometimes people have a response just to drinking alcohol or high sugar intake, or they're very inflamed in their body, causing this chronic pain in knees and hips and ankles. Things like rheumatoid arthritis and gout and fibromyalgia. My personal take on there that these are inflammatory responses, mostly to foods and environmental or medications. Things like statins can cause these types of conditions. So getting to the bottom of the problem is really what functional medicine is, and it's trying to find the root cause and not just treat the symptoms, which most of us can treat just throwing some medications or things at it. Psychogenic or centrally influenced pain. These can be things like tension type headaches, functional abdominal pain, somatization disorders, mechanical pain caused by structural distortion or compression. So lots of different reasons why people are in chronic pain, and so we can't treat all of them the same way. Every patient is different. And one of the things that I constantly see with chronic pain conditions, especially in my older patients with knee or back, is they have an intolerance to high load training. You know, I think there's something like 65% of the population over the age of 45 has a torn rotator cuff and has, shoulder problems, so they cannot be lifting heavy loads through the shoulder. And I think of the things that limits us. And if I'm sitting in the airplane and I'm watching people trying to put their luggage in their overhead bin and they can't do it because they don't have enough strength to do it, I kind of feel bad. I mean, I get up and help them if I can, but I think like, gosh, that bag is 25 pounds and people are having difficulty doing that. It really leads to a decreased quality of life when we don't have that function. And that's why I always say that being stronger is always a good thing. How do we get stronger? How do we tolerate these loads and these tolerances so we can do more activities that we want to? The problem with heavy loads is that they can flare symptoms. Light loads can feel too easy. Sometimes we get this pain, which then reduces our activity, which creates deconditioning, and which that creates higher sensitivity. So we can get stuck in this cycle of avoidance and inconsistency. So what we want to do in these conditions is we want to try to do what's called joint preservation. We want to do tolerable, repeatable loading. So for example, today I have a patient that is having a knee problem. He's having difficulty walking. So what am I doing with him? Isometric BFR quad sets, sitting on the bed or the floor. He has the cuff on. He's just doing quad sets, just contracting the quad. I'm just trying to maintain range of motion of the knee, especially that extension. He's trying to continue to build or maintain the muscle mass in his quad. And we'll do other things as well, like calf strengthening and hamstring strengthening and those things, but he's unable to tolerate it right now. So I'm trying to give him something that he can do. And isometrics typically can be done to most, unless they don't have range of motion yet, which we'll talk about in a second. So why joint preservation matters in chronic pain? We got these Heavy loads might create symptomatic flare-ups, so we're going to avoid those. But then light activity, if you've heard me lecture in the past, we know that if you just use light loads like resistance tubing and you're doing sets of like 10, probably not increasing strength and hypertrophy. It's not enough load. So we need to make sure that we're lifting enough to get that physiological adaptation that we're looking for. So we're going to use exercise as a joint preserving stimulus, and there's lots of different ways that we can do that. Most of the time without BFR, we're just going to decrease the loading. So like I mentioned before, doing an isometric. If I can't even do an isometric without pain, maybe I connect somebody to Russian stimulation like E-stim and just get muscular contraction to get the muscle. The cool thing with BFR is even if somebody can't do contraction, maybe they're right about to go to surgery or they're immediately post-surgical, we can use a cuff passively. Just putting the cuff on, inflating it for 5 minutes, deflating it for 3 minutes is called cellular swelling. I'll use this with patients that are in a cast or in a brace, and we can preserve their muscle. Otherwise, what happens when we're in a cast or brace, we typically get atrophy or weakening or loss of muscle mass. So where BFR fits in is it's allowing us to use these light loads, yet get the effects of heavy load lifting. And so we're reducing that external load to reduce the stress on the joints. And if you're not familiar with what BFR is BFR is basically taking cuffs, these specialized cuffs you can see in the picture, putting them at the top of the limbs, either the top of the arms or the top of the legs, and we inflate it to a certain percentage. And what that does is it prevents blood flow leaving the limb. Venous return basically gets cut off. And we partially restrict, not fully restrict, partially restrict the amount of blood that's going into the limb. And what's happening there is that your brain thinks that you're doing very heavy lifting because of that decrease in oxygenation. And we get the physiological adaptation without the mechanical tension, and thus decrease the mechanical load on the joints. So lots of studies looking at not just strength and hypertrophy changes. We know that, I mean, there's got to be over 2,000 studies now. I haven't looked at the actual number in a long time, but I know when I started researching this back in 2016, there was over 900. So there's been a lot of published papers in the last few years, but this was one systematic review in 2023 where they looked at 6 different randomized controlled trials, 189 healthy patients. They used BFR, and what they saw was that you got this hypoalgesic event after the exercise. So meaning that you reduce pain after the exercise. Now this happens with regular exercise too, but a lot of people can't tolerate the regular exercise. So that's why we use BFR if we can't. What they found in those studies was that higher occlusive pressures mean greater pain reduction. So in the upper extremity, we use something called limb occlusion pressure to measure how much actual pressure should we be inflating the cuffs safely and effectively. And so think of it as a blood pressure cuff. We inflate the cuff to a certain millimeter of mercury. And so you're using, in the upper extremity, you're trying to reduce pain, you're going to use the highest pressure, which would be 50% of your maximal or limb occlusion pressure. And in the legs, you'll use 80% of your maximal compression or limb occlusion pressure. And so we're using these high pressures to try to provide a better analgesic effect, if that's the goal. We create that window of opportunity that I talked about before, where we're getting this decreased activity or decreased pain sensitivity, and then we do more into that. So we do more range of motion, we do more high quality movement practice, we work on things that we're not able to work on when we're having more pain in the joint or limb. So we're keeping the stimulus while lowering the joint cost. And that's the whole thing about BFR, why we use BFR. It's all about decreasing the amount of load necessary so we don't overstress the joints and the tissue. So one of the things that Dr. Lonicki out of Old Miss has really published quite a bit about is this decision pathway on how to choose the right track. What am I going to choose of a way to use BFR, since there's so many different ways to use BFR? So number one, we always recommend making sure that you're screening yourself or your clients first. Make sure that above all else, we do no harm. So If there's any contraindications like clotting syndromes, immediate surgery, pregnancy, things like that, you got to get cleared by a medical professional. So always screen first, make sure it's safe. Number 2, mobility check. Do you have 90% range of motion of that joint? And if you don't, then we have a mobility issue, and we're probably not going to try to do a bunch of regular resistance training. We're going to probably think about doing either passive BFR or walking BFR or something different. How much load can they tolerate? Can they tolerate a light resistance like 20 to 35% of 1 rep max? And so you can use this as a guide. If you're not mobile, you're going to use more of a passive, which is called cellular swelling, which I mentioned before. If you're mobile but you can't load, we might do something like a walking track where we just put the cuffs on the limbs and we go for a walk or on a bike. You can't tolerate heavy loads, then you use low load BFR strength training. And if you can tolerate heavy loads, then use heavy loads, but also use BFR as an adjunct, meaning on an opposite day or after your normal workout, just to get what I call like a finisher. So for example, if I've got somebody doing an upper body pull day and their goal is to increase their bicep size, what we might do is a heavy resistance day of all the pulls that I typically will do, but then I might finish with one exercise with BFR doing a bicep curl, just a very concentrated, isolated joint, just working on hypertrophy at the end, and we're totally fatiguing that tissue to try to get good hypertrophy or muscle size. So again, checking the safety, make sure you're using appropriate equipment and you've been educated. If you haven't been, I've got a lot of free stuff that you can go on and get educated on. Screen for risk factors. Start conservatively. I always recommend a 2-week on-ramp, meaning you're using lighter pressures, you're using less sets, you're using less exercises for the first couple of weeks because you will get some soreness from this. And I've done it in the past where I blew somebody out of the water and they never wanted the cuffs on them again. So after a first session. So you do that once, you don't want to do it again. And so that's why I recommend like a 2-week. The research shows it takes 3 sessions to kind of get used to BFR. And so you're looking at about a week or 2 of kind of just gradually building up to the point where you're using it full go. From a screening standpoint, just make sure that you're going to stop if you have an increased thrombus risk history, significant cardiovascular disease, uncontrolled hypertension, you have an elevated muscle damage risk or any type of special population. Just get a consult before implementing. Check your mobility. That's the second thing. Is your mobility about 90% or greater? Awesome. Continue on. If not, then you're going to work on your mobility things. You might do passive BFR. Like I mentioned, passive BFR is just inflating the cuffs and doing rounds of inflation to try to maintain muscle mass. That's called cellular swelling. And we do 5 rounds of 5 minutes with a 3-minute interset rest. So when you're setting your smart cuff, if you have the Gen 4 cuff, that is going to be considered intermittent BFR because during the rest period, the cuffs are deflated. Continuous BFR means that the cuffs are inflated both during the exercise and during the rest period. And resting BFR means that you're only inflating during the rest period. So we have continuous BFR, we have intermittent BFR, and we have rest BFR. And those are 3 different things that you can choose, both in the Gen 3 and the Gen 4 cuffs. So here's your cellular swelling. It can be used with people if you're watching them closely in a brace or a cast. You just want to watch somebody in a cast. If that cast is too tight and you create swelling in the limb, you can create a temporary compartment syndrome. So I don't recommend people do this on their own willy-nilly. This should be underneath a medical provider that's been certified in BFR. You can perform isometrics while you're doing the cellular swelling protocol. You can use isometrics and e-stim all at the same time. These are all ways to progress up to the point until we can actually start lifting. And again, it's 5 rounds of 5 minutes with a 3-minute rest in between using continuous BFR. Let me stop sharing for a sec. What method do you use to determine LOP? What percentage do you recommend for neurological patients? So I only use the SmartCuffs. Like I mentioned in the beginning, I'm the director of education for them. So it's built into our cuffs how to measure it because there's a Doppler built into our cuff. Think of like an automated blood pressure cuff. It's already built in. 4 years ago, before our Gen 3s, and when we only had Gen 2 and Gen 1, we used an external Doppler. And if you go on my YouTube channel, just under Ed LaCara, it might be under Ed LaCara or Dr. Ed LaCara, something like that, you can see me doing examples with the Doppler. And so we use a Doppler to determine what the minimum amount of pressure is necessary to fully occlude the limb. And then we use a percentage of that. So people with neurological conditions, depending on what that neurological condition is, I would always start low. I actually do this with all patients. I start low and I build up. So start off with 40% limb occlusion pressure and then go to 45 and then go to 50 in the upper extremity. I will say I use less pressure in the legs now than I ever have because I typically am trying to move the needle on the amount of weight that I'm using. So it's a variable and it's a clinical decision, but I like to keep the pressure lower in the legs and actually increase the load if I can, depending on what the goal is. Alina, I have some questions. I recently had my 6th knee surgery, same knee. I'm sorry, November 2025, transplant revision and ACL, all revision, having a lot of pain. So your post-op protocol is going to be passive. It's going to be isometrics, like with E-stim, just like we've just talked about. Is there evidence that BFR increases neuroplasticity markers? Yes, there is. And of course, the more that we repeat those movement patterns properly, that's going to also increase our neuroplasticity. And yeah, you're totally right. It's very difficult psychologically to deal with these injuries. I even see patients really get depressed over something that's only going to be a couple of days, like, and they're just not able to go out and do what they want to do. And it's hard because that's a lot of times what their social component is. If somebody's playing pickleball and they're out with their friends and they get lunch afterwards, and all of a sudden they can't do it. And what about creating more energy, i.e. being too tired even to want to exercise? If that's the case with my patients, is blood work and looking at how is your thyroid functioning? How's your hormones functioning? I look at the medications that you're taking because some meds are going to cause that. It's a multifactorial, but most of the time we're going to see an underperforming thyroid. We're going to see an underperforming adrenals, your testosterone, or not saying you, but whoever is having this inability or want to exercise. But it goes much deeper based on age and perimenopausal, menopausal. But, that takes a deeper dive into figuring out, like, how do we get you feeling good in order to want to exercise? I have a patient that wants to do BFR, but she has Raynaud's. That's a contraindication, correct? It's not an absolute contraindication. It's a relative contraindication. I wouldn't do it in a situation where they're going to be in extreme changes in temperature. But, start with light pressure, see how they tolerate, and go ahead. It's not an absolute contraindication, no. How does BFR reduce chronic pain at the central and peripheral nervous system levels? I think I've explained that you're basically creating a window of opportunity. I can't get into the whole neurological, corticospinal tract, and it's going up, one side and going to the other, and, it's blocking. Like that's not my expertise. But what we know is that exercise alone decreases pain. Now, it might be short-lived. It might be a day. It might be 45 minutes, but it does create these windows. What's the recommended protocol for patients with severe weakness or neurological impairment? So again, I would follow what I gave you as far as the guideline, which would be like, is it safe? First of all, do you have 90% of range of motion in the joint that you're trying to exercise? And if you don't, you're going to go to passive BFR. If you do have 90%, can you lift heavy weights? If you can lift heavy weights, lift heavy weights. If you can't, can you lift 20 to 30% of a 1 rep max or a light load? Even just, a lot of times I start patients without any weight. They're just doing like bicep curls, open palmed, no weight. They're just getting some activity through the limbs. And sometimes that's where we have to start with people. Follow that progression. And you can also look at some of Dr. Loenicke's work out of Ole Miss, because he basically created that algorithm of rule out contraindication, range of motion, no range of motion. Can I lift 30% of my 1 rep max or 20% of 1 rep max? And then what to do off of all of those. William, when incorporating BFR with other modalities, is there an order which is best? So I typically do my modalities first, and then I finish with exercise. If the pain response is too high to even do those modalities, you might consider doing BFR first, but you're going to get a reduction in pain just with doing those modalities. So that would create another window of opportunity to then exercise in, and then now you're creating a double window. I like doing my modalities, manual therapy, all that stuff first and then going to exercise. Because I always want to have the range of motion as best as I can. And typically I'm working on some sort of range of motion to start, get the range of motion right with my modalities, and then go into BFR to then groove that new range of motion. Can BFR improve corticospinal tract activation? There are in spinal cord injury patients. That answer is yes. There's been studies looking at spinal cord injury patients and improving. I've got patients that have spinal cord injuries that are using BFR in ways like on my Vasper, like that type of way. But they're either in combo with E-stim and things to try to activate the muscle. What advantages do automated BFR systems like SmartCuffs provide compared to manual cuffs? The automated cuffs, the big difference is going to be that you don't have to guess on your limb occlusion pressure. So it automatically inflates it for you. And that's been validated by outside researchers. So the pressure that you're getting is the pressure that you're looking for, which makes it safe and effective if you use it within the way that we teach it. What role does lactate play as a signaling molecule in neuroplasticity and motor recovery? I don't know if lactate plays a role. I'm not sure about that. Again, that's not really my wheelhouse. Can BFR slow muscle atrophy and neurodegeneration and neurological diseases? The answer is yes. You can even use it passively with BFR. People use them in the hospital. Let me ask, will using BFR help increase their energy levels? It's a tough one to answer. I personally believe that if somebody's not moving and all of a sudden they start to move and they do it kind of slowly, gradually, and safely, they tend to want to move more. Very rarely do I have people that finish a workout or finish an exercise bout or finish going for a walk and get done and say, you know what, I shouldn't have done that, unless they hurt themselves. So I'm going to say yes to that, but I can't promise it's going to increase their energy levels, but psychologically they'll feel better because they're moving. And so I'm going to say yes. I have a patient recently diagnosed with Cushing's disease and having a hard time working on her strength. Yeah, for sure. Yeah, it's not a contraindication. Again, start low and keep working up. What clinical protocols do you recommend specifically for neurorehabilitation patients such as stroke, MS, spinal cord injury? Again, it's no different. I don't treat patients like that any differently than how I treat everybody else. Just follow the same protocol. All right, is it safe? Do they have range of motion? If not, can they lift light loads? If they can lift light loads, do the light loads with BFR. If they can lift heavy loads. Using compression boosts like a Normatec after BFR, do you think the compression negates the effect? I wouldn't do it. I wouldn't do it for probably 15 minutes. By then you should have everything should be basically normalized unless you do a couple few, I don't really want to get into it too deep tonight, but ischemic preconditioning is another protocol that I'll use, which is basically 100% limb occlusion pressure, meaning you have full occlusion for short periods of time. We use that to prepare tissue for heavy, intense training. But other than that, that we know that you decrease ATP for up to 45 minutes. And so you never want to do that. Then, go out and try to do a max effort sprint or something. But you don't really want to you want the metabolites to accrue as best as you can. So I think if you wait 15, maybe 30 minutes after the exercise, I'm going to say 30 minutes after exercise, and then you can go into the cuffs. Thanks for the questions. It's great. Walking protocol, just to get us back to where we were. So track one was patient doesn't have full range of motion, or they do have full range of motion, but they can't load 20 to 30%. So they're not ready to load at all. So what we can do is a walking protocol, and a walking doesn't have to be just necessarily on a treadmill or outside. It can also be, it can be on a bike, it can be on an elliptical, it can be on some sort of hamster wheel. And what you're doing is you're putting the cuffs on, you're using kind of light pressures, and you're just getting them moving. And you do get a systemic effect with BFR. So even though the cuffs are on my limbs, let's say, I'm getting an effect throughout my whole body. And so you can have those cuffs on for 20 minutes at a time and then take them off for at least 5 minutes. And then you can put them on for another 20 if you want to go for that long. I don't think you need to go more than 20 minutes. I think 20 minutes is okay. A lot of the studies have been at 15 minutes and 20 minutes have shown increases in VO2 in even very conditioned athletes. Clark did a study in 2012 looking at Division I athletes doing 15-minute walks twice a day. Those were basketball players, so very athletic, increased their VO2 over the course of, I think it was 6 weeks. So you don't need to do long bouts with BFR, just like you don't need to lift heavy load to get the effect. You don't need to do long bouts with BFR to get the aerobic capacity effect. So here's just kind of protocols on how to do it. And by the way, you'll have access to these slides in that portal that I've built for these webinars. If you're able to tolerate low loads, then you can use BFR with weights from between 20 and 35%. I don't recommend going over 35 or 40% with the resistance. A lot of patients ask me, well, how do I know if I'm injured and I can't lift weights that are heavy? How do I know what my 1 rep max is? And you're right, you don't. So you kind of have to guess. And so we use this high rep structure, 30 reps. And then on the first set, keep the cuffs inflated. This is continuous BFR. So it's BFR, the cuffs are inflated during exercise and then during at rest. And then you do, after the 30-second rest, then you do 15 reps, 30-second rest, 15 reps, 30 seconds rest, 15 reps. And then you deflate. And so that's the continuous BFR. If you're able to do 30 reps and the weight is good, if you're getting through this set of 15, like this third set of 15, and you're not fatigued at all, the weight's too light. So you should be feeling at about rep 10 of this third set. I'm starting to get pretty tired, and then it's pretty hard to finish all 15 reps in that last set. Then you know your weight is right. So it can take a couple times, especially when you're using you're trying to rehab an injury, to find the right weight. So you make a note in your log and you go, next time I'm going to use 5s instead of just open palm, or I'm going to use a 2.5, or I'm going to use a 10 or whatever. And then low load BFR strength. So this is just kind of how to do it. How is your exercise selection? You can start with isometrics, then you can go to single joint or open chain models. Then you can go to closed chain, and then you go to compound. So that's usually where I'll take people. So an example might be, like I said today, my guy with the quadricep, knee pain, I'm going to just do isometric holds of his quadricep called just an isometric hold. Then if that does okay, then I'll probably sit him next week. I'll sit him at the edge of the table and he'll start to do like a leg extension and just was starting to do some quad sets. And then a long arc quad set. And then closed chain, we might start doing some wall sits or things of that nature. And then compounds are going to be more of your squats. Multi-joint is what a compound means. So this is what a beginner session blueprint might look like. 3 to 5 minute easy warm up, do a little mobility, jump on a foam roller if you like to. Choose your track. You're going to do swelling or mobility sequence or walking or low load BFR. And then use that pain window that you create to be able to do a little bit more improved work for that tissue. Here's just a couple of examples of like somebody with knee osteoarthritis. You're trying to tolerate, you can't overload that joint. Or if you have an irritable tendinopathy, you might use some isometrics to start. Somebody with chronic spine pain, I'll typically use walking BFR with them and just get them on a treadmill, 1% incline, and let them walk. You not only do you see an increase in cardiovascular capacity, but you also see an increase strength and size of the quads. That's what studies have shown with BFR walking. So what's normal is that you should normally feel some tightness or pressure from the cuffs. You'll feel some muscle burn and fatigue. I say stop with numbness, but in reality, a lot of times you do get some, and that shouldn't be severe numbness tingling, but you'll get a little bit, especially in the upper extremity. And the reason is that, you got these cuffs on the upper limb, and you've got nerves that are pretty close to the surface, not a lot of muscle mass there compared to the legs. And so you'll feel a little, you just don't want it to be extreme. And you shouldn't get dizzy, unusual swelling, or alarming symptoms. I will say that you definitely want to eat before you do BFR exercises because it's tough. I do have patients get a little lightheaded if we do some sort of compound exercise and they haven't eaten yet. So try to avoid flare-ups, and you'll know it's working. You can just kind of read through this, but if you're able to see improvement over time, I'm going from an isometric to a isotonic, and now I'm going to go to a compound. All these things are showing improvement. So key takeaways: chronic pain limits tolerance, not the need for loading. Joint preservation is about how we load, not whether we load. BFR bridges the loading gap when heavy loads aren't tolerated. The goal is consistency at first. Capacity and heavier loading can come later. So next month, I'm going to do rotator cuff focus, pull in some research and kind of what I use for BFR. Here's how you can get in touch with me. That's my office phone. You can send me an email. You can follow me on social media, which post some stuff on Instagram the best I can. But if professional, LinkedIn, whatever, YouTube, I have a bunch of videos on there. Here's some references for today if you want to grab a screenshot of those. So I have a couple different classes. So my BFR, if you're using it on your own, I would recommend the BFR bootcamp. It's not so in depth technically. It's more just like how do we get going with the cuffs? We go deep dive into the app so you're using it properly and correctly. We kind of plan it over like a 4-week, like, you're taking in this information. What do they call it when you binge watch and just kind of get it done pretty quickly. For professional certifications, we have level 1, which is kind of our foundations, more of a rehabilitation focus. Level 2 is more clinical and performance applications. And then we also have instrument assisted soft tissue mobilization course. All get CEUs and stuff. And so if you that's a screenshot of, or the QR code for all the courses that we do both live and online. Ever since COVID, our live classes have gone to basically zero. We used to do over 300 courses a year internationally. And I think that's down to like less than a dozen. It's pretty amazing how much education has changed since COVID. If you want to connect with me, here's my QR for Instagram or my YouTube. This is the SmartCuff Gen 3. If you don't like using an app, this is the cuff to use because it disconnects. So the cuff will disconnect from the unit. So some places like the VA, they don't order our Gen 4 because they don't want the Bluetooth. They want to use this instead. If you want to go swimming, then you want to use this cuff because this one is water resistant. And then these are the Gen 4s that are basically controlled from an app on your phone, either Google or Apple. And just because you're here, we get you an educational discount. Just use Education 10 on any products or courses. And that's it. All right. Anything else tonight? Yeah, Alina, you can swim with it. Normally, I recommend swimming it with it up high, but you could also use like a kickboard and put it on your legs. There's lots of different things you can do. You could put them on and then do walking in the pool. Lots of really great applications. Just being creative with it. Thanks, Nick. I appreciate your attendance. All right, y'all. If there's no other questions, I really appreciate your attendance, and I hope to see you next month and on socials. Bye for now.